I'm excited to have everybody here this morning, and we're going to talk about patient safety. And I wanted to start with a story. Some of you may have heard this story, but I think it has some implications in medicine and is worth a discussion. So Alcoa is the aluminum company of America, and it was a staple company in the United States for many, many years. In the 80s, they started to really decline, and they lost a lot of accounts, they lost a lot of profits and revenue. And so the board hired a new CEO whose name was Paul O'Neill, and he was working at a government agency, actually. And they wanted to have him come on and solve all of their revenue and profit problems. So Paul O'Neill comes on and he gets in front of the board and investors at a fancy Manhattan ballroom hotel, and he says, at Alcoa, we are going to be 100% focused on workplace safety. And the board was confused, and the investors were a little startled by this. And he reinforced the message. He said, I don't think you're getting the message. If you want to know how Alcoa is doing, you are going to look at our workplace safety data. And there was people that walked out of that meeting, called their investors that they represented and said, we just hired a hippie to be the new CEO of Alcoa. You should sell now. This is Alcoa's profits after that meeting. It soared in the tens of billions of dollars. If you would have invested $1 million in Alcoa when he made that presentation, you would have had $1 million, by the time you left in 2000, you would have made $1 million in distributions and had 5 times your investment value in the company. So you'd have had 5 times your revenue, your profits, plus $1 million, your money back in distributions. My question is why? Why do you think a focus on workplace safety had such a dramatic turnaround for a large American corporation? What do you think? Cruz, do you have a comment back there?
When you focus on safety, you turn your attention to operations, process improvement. You ask your employees to start looking after each other, which helps with culture improvement. So
yeah. So aluminum is dangerous. So if you can produce aluminum safely, you have to be doing a lot of things correctly. And I do think it had some profound cultural implications for the company. Other thoughts? Yeah, Steve?
If your employees or whoever's working with the aluminum feel like the company is behind their safety and willing to put their kind of money where their mouth where their money is or whatever, they're gonna work harder.
Yeah.
And they're going to be willing to come to work and work together as a team, like Amelia said, and I think it just builds a better culture around there. And if your team feels valued, then that's half the battle right there.
I agree. That's wonderful. Thank you. Other thoughts? Yeah.
It costs a lot of money if there's safety issues, right? Like somebody loses an arm in a machine, it takes a while to clean that machine and can't be running. So
yeah.
Lost profit.
Yeah. No, there was some real data that if they lost a worker to an accident, sometimes they didn't come back for several days or weeks or months, and there was a direct cost that was associated with that.
I think sometimes too, when you develop a system around safety, people feel more open to talking about issues because
yes,
they think, hey, they value this, so they're more open to talk when something's not going right, and so overall it improves your processes.
Yeah. I think inviting, when the goal is safety, you're inviting everyone to participate and it's almost like a many minds approach, right? Around a key indicator. These are all good thoughts, and I think that it's quite the story, really, when you go back and think about how he was able to turn an entire corporation around with lots and lots of problems, focused on one thing that I think everybody could agree was important, and then using that with key metrics and key data to improve. There's lots of safety data out there. I'm sorry, I'm in your way. There's lots of safety data out there in the literature, and I think that you could say that we really don't do a great job in medicine in the United States. There's far too much iatrogenic injury, far too many medical errors. I don't want to get into it. This is a recent article that Dr. Bowden brought to my attention from the New England Journal of Medicine, that a quarter of patients admitted to the hospital have a significant medical error made, so it's very high. What can we learn about this Alcoa experience as it relates to medical safety in medicine, safety for our patients? Yeah, Todd?
Patient care, the business of medicine will come.
I love that. Thank you. Yeah, sometimes I think all of us get a little bit distracted sometimes for one reason or another, and lose that focus on patient safety and outcomes. It's easy to do. Yeah.
If the patient, if all of your patients realize that you're an organization that is, from top to bottom, really focused on their best care.
Yeah.
Like, and not making decisions that are just about the quickest decision, but the decision that is best for them, spending time to talk to them, spending time to listen to them, then they'll buy in more to the things that you're asking them to do.
I love that. Yeah, I think if patients are attracted to that, and I think all of you do that, and then as a community we strive to do that, and I think patients want to see that for sure. Alex?
I think longevity is a word we've been talking about a lot, and I think that's really the focus with this, is having a bigger picture mindset of, in a surgical case, a lot of times you have to make a decision in the moment. We have a scheduled surgery and somebody shows up to the OR that day, and then maybe their blood sugar is elevated or their blood pressures are not on a safe level, and could kind of push the issue to just move forward and take care of the problem right in front of us, but having a bigger picture in mind of what's really better for this person might delay a minute, and they might have to come back another day, but to do it safely, I think, puts that into perspective. That's really the best care for the patient.
I love that, and I think the theme of the conference upcoming is going to be longevity, thinking about what is the best for our patients now and in the future, and how we come together around that as a community. And I think that having that singular focus is a good thing.
I think a lot of it's putting pride aside. I think that's
the
hardest thing to do as providers. But I think the idea there is we want to focus on what's going well in our practices, but I think we need to always take time to reflect on what we can do better, and things that have happened, morbidity, mortality, just any type of complication that you've had. We should be continuously looking back at those instances and seeing what went wrong, and collaborating and doing exactly what we're doing here, continuing that conversation. So.
Tyler, I think, epitomizes that mentality in our practice and in our community, just this willingness to always be looking to get better, and just almost, really no ego whatsoever. And I think we want to strive to be like that individually. It's easy to just try to justify what you did or make yourself look good, but that's not probably the right approach if our singular focus is on our patient outcomes. Yeah.
One thing that I think about that Amelia alluded to is a processes, like measuring things, the importance of measuring.
Yes.
What you measure improves.
Yes.
And just that, like looking at that data, and what does that data tell us?
Yes.
What can we change because of it?
We want to be more data driven. One of the things that I think as I studied this story more and more came to my mind is by focusing on safety. And if you want to know how Alcoa is doing, you would look at our workplace safety data. It was data driven, and we aren't always great at managing our patient outcomes and collaborating, working together based on real data. Part of it's because it's hard to get, but that's one area that we could certainly improve on. Thank you. Carolyn?
I think inviting our patients to give us some of that data is really helpful.
Yeah.
So recently at our last visit with our patients, before, when they're done with surgery 6 months or a year, I started saying, I think I stole this from Todd. I started saying, what about your experience with us do you think we could have, in what way could we have done better?
Yes.
And it's funny, most of the things are like, oh, well, you couldn't have done this, but I waited 2 hours in the OR. Like, it's some information that they're giving us about ways that maybe we didn't directly impact them, but maybe we could reach out and kind of say, hey, how could we help this process be better for our patients, right? And so I think sometimes the data it depends where you're getting the data from,
yeah.
Right? And what is better than getting it directly from the patient and saying,
filtered Google reviews really are the best.
right? Like them looking at you going, what could we do better? We want to make this better for other people.
Yes.
Right? And
yeah.
I found that to be like a little vulnerable while you're sitting in the room, they're looking at you, you're like, oh my gosh, but also very valuable.
Very valuable, and it's okay. It's okay to be vulnerable, I think. And none of us are perfect in what we do. And I'm going to share a story later that is vulnerable for me. But boy, it's nice to learn and be better. And that's what our intention should be. Not so much to just pat ourselves on the back and move forward feeling like we did a great job, which I think sometimes we do have a tendency to do. You all do a very good job, though. So thank you. This is great comments. So this is a picture in the operating room, and a few years ago, Intermountain had a safety initiative, and it's posted up on the wall of every operating room. The main focus of this safety initiative, in my mind, was the surgical timeout. And we're going to do timeouts well. We're going to really make sure that we get it all in there. And we even had some fun with our timeouts. Chandler likes to say that we shouldn't stab each other and light each other on fire. Just a reminder about sharp safety and fire safety, and having some fun with it. There's an element, though, in the 3-part safety plan that I didn't recognize its value initially. The first is a time in, and then there's a time out, but then there's a debriefing process. And if you look very closely, which you can't really see it, it's listed there. And Dr. Brock's husband worked in the military, in the Air Force. In Korea and Vietnam, the Air Force had lost a lot of pilots and had a lot of problems in combat. And they really looked carefully at what they could do to be better, and decided that they would use this debriefing strategy, which is the most rigorous in the military in the world, as a part of the culture of the Air Force. And so the process is that you have a mission objective, you build a plan, you execute the plan, and then immediately after the execution phase is your opportunity to debrief. And Dr. Brock's husband would say that they would have a short flight period and a very long debriefing period sometimes. There's 3 components to a debrief as I was reading about it. One, it's immediate and factual. They had footage, they had data, they had statistics on the flight. Number 2 was a single individual runs the meeting, not necessarily the highest ranking individual. And number 3, there was no rank and nothing personal in the meeting. Errors that were identified underwent a root cause analysis. So, does anyone here in your day-to-day environment, your teams, do you do a debrief?
We do it in the ER after every trauma.
Okay. Talk about how that's been beneficial or what you found in them.
It's beneficial if you do it immediately after
Uh-huh.
the trauma, so you don't necessarily wait days, right? So it's fresh in everyone's mind. Kind of go over the case, what went well, what didn't go well,
Mm-hmm.
what ways you could improve, and it gives people a chance to like emotionally process.
I love that.
happened.
Yeah.
So, but they do it after every
Yeah.
trauma.
How long does it usually take?
5 minutes.
So not
10
not a ton of time.
So you do it on shift when
Uh-huh.
things are happening, so everyone takes 5-10 minutes to
Yeah.
go over it.
Yeah. One thing that I read, and I think you just mentioned it, is it allows you to deal with the emotions of something, especially with a trauma, and sorry, Mountain Point's calling me. Especially with the trauma, and put it in the past, right? And I think sometimes in medicine, you linger on to all of those things, and it could be a recipe for burnout as one benefit of a debrief.
We tease and say it's like trauma bonding, right?
Yeah.
Like sharing all of it together. But
Yeah.
really, I love that idea that it kind of allows you to process it and move forward.
And I like that in this idea of looking at how things went, you felt like you bonded. You didn't feel like you were
Exactly.
butting heads with each other.
Right?
Yeah.
So not often in the physical therapy world, but a couple of times, maybe a couple times every 5 years, we'll have to transport a patient.
Uh-huh.
I.e. call paramedics because they're not doing well, and usually they have some sort of an underlying medical condition. And in this instance, it's a great opportunity to gather your team together and say, what went right,
Mm-hmm.
what went wrong, what were the precursors that maybe we could have caught this sooner. And so I like to use this sort of debrief when there's a bigger event as a way to just train the team and then develop new policies. We're like, okay, what could we do better?
Yeah.
And then we'll sort of build in, the next policy. And now, even with what we have now, we have just a policy built in. If we have transport a patient, there's certain things that are supposed to happen.
Mhm.
Their face sheet, insurance card, all their past medications, all that is printed up waiting for the EMTs, so when they get there, so
Oh,
they
yeah.
have all that information to take with them, so we don't have to worry about that. And so these processes are built over things that sort of fell short on the first couple of times that I went through it. But
Yeah.
they're great opportunities to kind of learn from that, can you tweak your processes to create a better experience for not only your staff but for the patient?
I love that, and I love how you took from that experience and put it into rigorous process, because I think a lot of our safety ends up being commitment to doing things in a specific way routinely every time, and being open to adjusting how we do things and using that experience to make the adjustments for the future. Thank you. Other, Chandler?
So we use the debrief in the OR, and it's a moment to go over, hey, what did we do? Did we do anything different than what we planned to do when we came into the room? Were there any issues? How can they be resolved? Was there any specimens or things that we gathered during the procedure? Did we get those correctly done? And that, I feel like, in multiple instances has helped us either fix a procedure written up that we have it written correctly. If there was any equipment issues, we can address that at that time and find the right person to work on that. But it also helps with patient safety if recently if something was forgotten or, oh, we were supposed to add this to the procedure. It just overall brings us back to what we were all doing, working on together as a team.
Yeah, I love that, and I appreciate your commitment to doing that and Sometimes it's like, well, why do we need to? You know, we just had a good surgery or something. But just that commitment to always assessing and recognizing where we needed to be a little better or where there was a mistake made or something like that. Tori?
To follow up with the OR one, we just recently had a case where it was at the end and everybody had a good time. It was a great surgery, things went smooth. And it was like, hey, so we did a decompression at L2-3 and we fused 4-5, and it was like, we were supposed to do 2-3? Like, sometimes you get so caught up and focused on what you're doing. That it's good to go back at the end and be like, hey, we did everything that we were supposed to, right?
Yeah.
That patient doesn't have to come back. We didn't have to wake them
Right.
up. Like, it was a really great catch.
Yep.
And so they're really important, just to make sure that you did what you said you were going to do.
That's perfect. Thank you. Carolyn, I think you're planning on speaking.
Next month.
Are you scheduled?
Yes.
Good. You mentioned the trauma, and I think there's a lot to be learned from how traumas are handled as it relates to general medicine, because the team comes together. There's a lot of things about the way a trauma is handled that's so good and gets lost as we get further and further away from the immediate need of medical care in a life-saving situation. We're not held often to the same rigorous standard, I guess, when we get into further away from that setting. But there's definitely things to be learned, and I think that thinking about how you might use a debriefing strategy in your operations, whether you're in clinic every day, whether you're in the operating room, whether you're working in the medical device industry, having an opportunity to periodically, after you've carried out your objective and mission, to say, how did we do? And I can promise that you'll find things that you could improve on, make the improvements, and see things get better. All right. I wanted to conclude with, speaking of being a little vulnerable here, a little story. And this happened a couple of weeks ago. So Brandy and I were doing a lumbar fusion, and this is the view that you want to have on the left when you're done. The dura is not, there's no pressure on the nerves. It's all free. You can see the dura. The nerve roots are inside the dura. There's no spinal fluid leaking. And in this case, we had done an interbody cage, which goes in just to the side of the dura. So we were doing a revision lumbar fusion. So there was some scar tissue involved. And the patient was a little bit on the frail side of things. We got in and we put the screws in. And I noticed that the bone was not maybe as strong as I would like, and the pedicles where you put the screws in were very small. So I thought we may want to try to get a cage in, kind of as we put those screws in. And then we did our decompression, and the decompression was a little tricky. And we noticed that the dura was thin in places and scarred in places, and you just have to be really careful, right? So we got through the decompression, and I felt really grateful that I hadn't done anything bad, right? Like, it's all good. And then I was like, okay, we've got the nerves free. I felt like I can relax a little. Now all we have to do is put the cage in. So we go to pull the nerves over with the retractor like we always do. And we're under the microscope, and it's in the room. It's on the big screens. There's probably 8, maybe 10 people in the room. And it was literally like all of a sudden the dura just exploded. And the nerve roots just came rushing out. And instead of looking at a nice, peaceful, happy sac of nerves, I was looking at the cauda equina. And I've probably done 8,000 surgeries in my career. I've never had this experience before. And it was a little stressful, like a lot stressful. It was scary. Chandler was there. I think she could speak to some of the emotion. It's emotional, right? It's scary. And so I was like, okay, so I've trained myself, you know what you're going to do. If you get into a sticky situation like this ahead of time, you've built out a plan, you know what to do, right? So get the CSF leak stuff. We're already under the microscope. Get the DuraGen, expand your laminectomy, make sure that you have stopped all the bleeding, get the nerve roots back in the sac, sew up the sac. Okay, let's do it. So I started into that. And for 45 minutes, I could not get the nerve roots to go back in the sac. And all the emotion comes out. It was like paralysis and neuropathic pain and numbness and dropped feet and bowel and bladder and, what are people going to say? I mean, everything. And I'm just like, what am I going to do? And so I had read the night before a verse from the Bible that says, be still. So I thought, well, nothing else has worked. I'm going to try that. So I just said, you know what? I'm going to just step back and reevaluate. And I did that. And I had a feeling of calm in a feeling of tension and feeling stressed and rushed. All of a sudden, a feeling of calm. And I thought, I don't know, your assumption about the dural tear is wrong. Your assumption about the dural tear is wrong. I thought, oh. So then I reevaluated things and realized that what seemed like an exploded dura was really a small hole through which not all of them, but nerve roots came out through. Okay, so then I looked more closely at that area. Then I thought, I've been trying to get these nerve roots back in for 45 minutes and have been unsuccessful. And then I thought, roll the patient away and tip the head up. I've never done that before. I've never been in this situation before. And I did that, and gravity pulled the nerve roots right back in to the fecal sac. Okay, this is good. We're doing good. And I just felt a profound sense of calm. And then I thought, well, how am I going to sew the dura? Because it's a frail lady, scar, thin dura. And this was like wet tissue paper, trying to sew it with a stitch in a tight spot under the microscope. I put a stitch in and just pulled right through. And then the thought came, put it through the scar and put another stitch on the other side through some redundant ligament that was still there. That's not going to do anything, but okay, it's working so far. So I did that. And and then I thought, oh, I can put my little patch right under that stitch. And I slid it under the stitch, and it perfectly buttressed my patch and plugged the hole. So the stressful part of this was mostly over. We did a brain tumor next, and then went up to the floor to talk to the patient. And she was awake at this point, and we hadn't really had a lot of phone calls, so that was good. How are your legs doing? How do your legs feel? She's like, well, all the pain I had before is gone. Do you have any numbness in your legs? Nope, no numbness. Let's test your strength, full strength. And we walked out just grateful. And I want to reiterate a couple of things as we think about patient safety and outcomes. That really should always be our focus. We had the biggest healthcare breach in United States history in February. I think it's probably affected some of you. It's affected us. It's not been an easy thing. And it would be very easy to go and focus entirely on that. And we do need to worry about it. But we always want to be focused entirely, really, on our patient safety, patient outcomes. In this setting of all of this, Chandler was there. Our team wasn't griping, Dr. Edwards messed up again, stressed out or complaining, and I wasn't yelling at them. The team was able to handle this. They were doing everything they could to remedy the situation. And I think one lesson that I learned from a dramatic situation was that safety is a team sport. The second important lesson is sometimes in the busyness of clinical medicine, the best thing we can do is slow down, be still. If something's not working, take that opportunity to reassess your assumptions, because a lot of clinical mistakes are made off of a poor assumption and then subsequent anchoring on that mistaken assumption. So with that, I appreciate everyone coming this morning and for your all that you do. It's incredible to me that we can get crews and everybody else here at 7 o'clock in the morning every Tuesday, and it just seems to be more and more fun. And I think it's because we all are interested in improving our outcomes and working together, and that's just a wonderful thing. And I think we just keep working on finding things that we can do incrementally to get better and better. So with that, appreciate it, and thanks for coming this morning.